You are live. Thank you. Welcome back to the Vermont House Appropriations Committee. It is Tuesday, January 7th, 2023, a little bit after 1 o'clock. We have with us this afternoon the, better known as DEVA, Department of Vermont Health Access. Oh, no way. God. Great. We have you for a good amount of time. Then we have a break, and then in the after that we have the Department of Public Service, and that should round out our day. So we have in our possession right now your physical copies of what you have up on the screen, and JFO went to get the better known as the binders, the bigger binders. So we can start with this. You were with us before, right? Do we do introductions again, or are you?
I think so, Madam Chair. But nice to see you. Nice to see you, members of the committee. For the record, Andrea Delabriere, Department of Vermont Health Access, otherwise known as DEVA. Joining me today is Patrick Rooney, DEVA CFO, and we are here to present the FY24 budget, which requests nearly $85 million in additional appropriations. That's gross. And from here, you'll see some common themes that you saw during the BAA presentation that are now part of our FY24 budget request. And let me, at this point, hand it off to Patrick, if that's okay, and we'll go from there.
All right.
Thank you, Commissioner. Good afternoon, everyone. For the record, Patrick Rooney, I head up the finance team at the Department of Vermont Health Access. Before we get going, a couple house cleaning items here. When reviewing the documents again over the weekend for the 900th time, I found a couple of items that require some clarification. As they're getting your binders, the documents you have in front of you should supersede what we have in there for the ups, downs, and the narratives. We found a couple of items related to the ISF that went a little awry. So number one, in the ups, downs that I have up on the screen here, these rows were omitted, rolled up in the ups, downs that we provided for the budget book. You have a corrected version of that. It didn't affect any of the totals. It was a formatting issue. But for purposes of transparency, we wanted to bring that to your attention.
So do we have that now?
That's correct.
You have that.
It's all the internal service.
Have that corrected.
Can't read the screen, so.
Yes.
Okay.
And then also related to the ISF and the narrative, we had a totaling issue here as we attempted to break that out. So this is the corrected number. The one in your budget book that you'll receive is $41 understated. So nothing of significance, but for correcting the record, we wanted to bring that to your attention this afternoon. And with that, we'll dive in. You have all become very in tuned to what the ups downs document is, so we'll skip that primer that we did during the BAA. So as the commissioner alluded to, our request for 2024 is a gross amount of just under $85 million. And that is the sum of the administrative appropriation of $20.6 million and the 3 programmatic appropriations, which is $64.3 million. And we have here up on the screen the same layout we had for BAA, where we've tried to provide cross-appropriation summaries of the work that we've put before you today.
So it's 84 million gross. It's a 33 million stated.
Correct. For the administrative component of our appropriations, again, 20.6 billion gross, just over $895,000 state impact. And this consists of $2.6 million gross of salary, fringe, retirement, and healthcare changes. This is related to DEVA's recruitment efforts, trying to compete with the private sector, the collective bargaining agreement, healthcare, and pension costs increases for the agency. We're projecting no change in full-time equivalent positions of 373 individuals. And that has a state fund impact of $1.15 million.
Nope, Representative Tolino.
Just a flag. I asked Commissioner Gresham when he was in last week, sort of a statewide look at where we're trying to use incentives or other programs for the workforce, internal workforce dynamic, and asking, yes, a look back, but also sort of forward looking. What is your forecasted outcome? You know, how are you foreseeing your efforts changing the expected outcome in the future, and what is your target and benchmark for measuring. That may all come through him. I'm not saying it has to come independently from you, but if that is something that you can feed him good information, would be helpful.
Okay, great. Okay, next up is a $139.7 thousand gross increase in internal service revenue, or internal service funds. This is, as you can see, several factors. These are shared services that all agencies and departments feed into covering the cost for. As you can see, we have Agency of Digital Services, Department of Human Resources, the Vision platform, and various insurances that we have to cover the cost for. And that is a $29.8 thousand state fund impact. The next two items are both related to the Medicaid Data Warehouse project. The first is a contract with Gainwell. As you can see, there's no state fund impact here. It's $654,000 gross impact. Gainwell is the organization that has handled Medicaid claims for decades now. So any improvement to the MMIS system via the MDWAS project would need to involve them in a major way to feed data, analyze data, provide feedback, and make sure that that information is flowing as it should into that new platform. So there's a contractual component of our budget that relates to that. Number 4 is the actual estimate of what could be spent in the coming fiscal year for the MDWAS project, $17.8 million. Again, no state fund impact to this. This is federal dollars that will be utilized to bring this program up and running.
Representative Shaw.
Great, thank you. Lots of money. It looks like it's an IT sort of project. Is ADS overseeing this? What's their role?
So we have, we partner with ADS on all IT projects. So yes, they're involved, and the procurement aspects of the projects are distributed between either the Agency of Human Services or ADS, depending on the arrangement. But yes, they're very much involved.
Yep, go ahead, Sue. It's really basic. What's the difference between 3 and 4? I mean, other than a lot of money.
The Gainwell.
Gainwell contract?
Yeah, so what's,
Yep.
this is the Gainwell is,
Gainwell is
tell me,
our
Bree.
fiscal agent.
right,
So they process our claims and also help us with reporting for CMS requirements and such. So they have been, we've had a longstanding relationship for approximately 40 years with Gainwell. So they are there, and any enhancements we would make, which is what the Medicaid Data Warehouse project is all about, those are enhancements to modernize the technology, meet Vermonters' needs, meet our reporting needs. Any changes we make to Gainwell via this new project needs to be accounted for.
that's 3. In other
That's
words,
3.
Yes.
in other words,
3 is
4 is the
there.
project, 3 is
Right.
what is paying Gainwell
Gainwell to make
Gainwell
the
to make the
connections.
connection.
Yep.
Okay,
Exactly.
got it.
Correct.
Thanks.
Yes.
And again, just to reiterate, the Medicaid Data Warehouse, the negotiations with vendors are still ongoing. So this $17.8 million is a high-level estimate of what could be spent in fiscal year 2024.
Could be less.
I'm not
We
going to
hope
answer
so.
that.
Maybe more.
The next,
It'll be an RFP or
what's that?
Yes.
it'll be an RFP, but it hasn't, the RFP hasn't been issued yet.
The RFP has been issued.
It has been,
Yes.
okay.
Representative Page.
Any idea when the contract will be awarded?
That's a great question. We're hopeful. I can't provide a real time, I would say in the next few months-ish, but I can't commit to a date. You know how these contract negotiations go. Hopefully it won't be that long.
Okay.
The next two, 5 and 6, are related to really some changes in the workplace environment over the last several years. The first one being reduction in office rents, $488,000 gross, $209,000 in state fund impact. Over the last couple of years, DIVA has been consolidating its physical footprint and at one time also held offices at Global Foundries in Essex Junction. Those have since been brought to Pilgrim Park here or in Waterbury near the main complex. So we did an analysis of the last few years of our rental spend in our budget and realized that we weren't coming close to that anymore with the consolidations that we've made. And so we had room to gain some efficiencies there to suppress the cost of the administrative side of our budget.
Has remote working played an impact in this area at all?
Yes, and also the next one as well, the operational production. So the hybrid work environment that we've embraced at DIVA means that we're making better use of remote capabilities and technology. We have people who can attend seminars on the other side of the country now remotely, which works in our favor in the way of not having to pay for reimbursement for things like mileage, meals, lodging, et cetera. And we've been overspending on that the last few years and really have no need to continue with the level that we are. So we have some area here to reduce operational spend and gain some efficiency in that space. 166.7 thousand gross and 8.4 thousand.
We've been underspending, right?
Yes, we have been underspending. Yep. And that rounds out the administrative side. Pause if there's any further questions before we move into the program.
I should probably give them a look at that. I think this is probably a great time for me to share that the agency approach to the budget development this year was actually a whole agency approach. So you'll see some common themes as we had discussed in the BAA, but you'll also see some other things that will require some explanation. So the whole agency approach really allowed resources and dollars to be distributed to areas of the agency that perhaps couldn't have been served otherwise in previous years. The other side of that is it allowed departments less discretion in providing other opportunities for enhancing needs, for example, which we'll talk more about. But I just wanted to kind of level set here as we walk through this, it really was a whole agency approach to the budget process this year. So I'll let Patrick take it from here.
Okay, we're moving into the programmatic side, which has 3 appropriations that make up this $64.3 million gross figure, 32.6 state. Again, this is the facilitation of the Medicaid program itself. So it's no surprise that this is the largest component of our budget. As opposed to the BAA, you can see our caseload and utilization request is much, much smaller than the 45 million gross we came with. And that is because of the activity that's going to occur around continuous coverage as we begin the renewal process, which has been on hold since the PHE was established in March of 2020. With that quote unquote unwind happening, their redeterminations will start. And the Medicaid rolls should begin to come down. And every Medicaid member is going to undergo this renewal process. It is a federal requirement. However, we do have over the next 12 to 14 months some federal FMAP changes that are going to assist us. Originally, that enhanced payment was going to drop off after a short period of time. Now they're going to step it down. So we should have some enhanced coverage of costs as we work through that renewal process over the next year.
So when you say step down, I just want to make sure that I understand. So it's not eliminating somebody there, or help me to understand what you mean by step down.
Sure. So we've been carrying this as part of this continuous coverage component. The state of Vermont has received an enhanced FMAP of 6.2%. Originally, they were going to cut that off, and there wasn't going to be anything.
6 to 5.
So yes, they have a step down process for that that's going to carry us through the renewal process. But you can see here that caseload and utilization is coming down about 4.5 million for this request. It's still an up, $2.8 million state fund impact. We do have 3 years of pandemic activity behind us, which makes it very, very difficult to predict what the need is actually going to be and with the renewal process and who will stay and who will come off Medicaid coverage. So we can take that number as really a best guess, to be candid with you. That does come at the work of the consensus group, which is central office, JFO, finance management, and DIVA coming together. And that is across appropriation impact, as you can see on the screen. Global commitment, state only and non-waiver. Global commitment carrying the largest component of that, for that increase. The next four, just like in the BAA, as the commissioner alluded to, common themes are all related to the Brattleboro retreat. And the themes are all the same as they were with the BAA. Number 8 is the alternative payment model year 2 shortfall. We requested 3.6 million gross to bridge that shortfall in the BAA. Now we're building into the base budget for the existing contract. That has a $1.5 million state fund impact. Number 9 is the enhancement of what in BAA was the year 3 alternative payment model amendment. We are now building that component into the base contract. And as the consistently giving gift, these alternative payment model contracts run on a calendar year basis, but we operate obviously on a state fiscal year. So we've got this cleaving of state fiscal years that exist within, cleaving of these alternative payment model contracts that exist within our state fiscal year. So again, we have this little visual up here to show that there's going to be a portion of this that exists in the first half of 24 and a portion of this that exists in the second half of 24. But they're 2 different alternative payment model years. And what we know now is that things will not change as far as the per diem rate and the Medicaid bed count. So we're basically carrying that number over from BAA and building it into our base budget. And that's $18.7 million gross. And the state impact is $8.1 million.
Somebody have their hand up? Nope, okay.
Okay, the next 2 are interrelated. This has to do with the Institute of Mental Disease IMD investment dollar phase down. We talked about this in our BAA. We have an 8-year runway to do this. So this is the second tranche of funds. The same amount from a gross perspective is being shifted. The best place to see this is on the ups downs in appropriation 309 under the investment column. You'll see in red, $4.9 million and $4.96 million being subtracted from that investment column. The 4.5 million is going up into global commitment under appropriation B307. And the 4.98 is being shifted within that B309 state only over into general funds. So here I can pop up the ups downs on the screen behind me here. So when I refer to the first appropriation, you see here in the investment column, we have the 5.9 and the 4.9. 4.5 is coming out of the investment column, and it's being brought up over to, let's see here.
Yeah, where is it?
It's on the second page of that.
Oh, that's administration. Sorry, I scrolled too high. Is right here in B307. You can see number 10, Brattleboro Retreat funding shift to GC. And then the 4.98 million is coming all the way over to the left in that same appropriation, general fund. And that is number 11. So the dollars are being pulled out of investment and they're being split into GC, 4.5 million, and GF, 4.9 million in the state only.
Am I looking at this right underneath the B309? That 9.5 under out of investment? Yep, okay.
Yep.
Madam Chair, I get the 4.968, the 4.944, 4.59. It's now shown as a decrease from GCF. Where does it show?
So that's going up.
Where does it land?
Yep. So go into B307. That's a global commitment. So it'll be the second box there at the bottom. Yep. And in that column right there where there's only global commitment dollars, you'll see 4.5.
Yeah, got it. Okay.
Yep, there it is. And that concludes our Brattleboro Retreat portion of the program. Next up, we have number 12. This is annual Medicaid rate adjustments, $914,000 gross, $395,000 state funded. Predominantly, this is related to federally required increases to qualified healthcare centers and rural health clinics. But as you can see in the narrative, we also have kind of a mishmash of other things happening in there around professional services, outpatient services, DME, prosthetics, physician administered drugs, et cetera, that exist within that $914,000 rate adjustment increase. And that has a cross appropriation impact, as you can see from the table below it. Predominantly that occurs in the global commitment portion of our budget. Number 13 is the annual Medicare buy-in and caseload changes. This is a group that doesn't really change in number that much year to year. The caseload remains relatively consistent, but we do have an aging demographic here in the state of Vermont, which is driving this increased request for those dollars to be used for buy-in on behalf of duly eligible beneficiaries. That is another cross appropriation impact that we've aggregated here in the table below. Again, most of the money is coming at a global commitment, smaller amounts coming out of the non-waiver appropriation.
Go ahead.
Just to clarify this, and probably talked about this last time. So being able to buy into Medicare means that we use fewer Medicaid dollars, so it saves us money to do it this way? Is that right?
On the buy-in,
On the buy-in?
let me see if I can,
It says who would otherwise be fully covered by Medicaid programs.
so it's like, is it Medicare that
You're
you're
buying into Medicare, and
So
using
that-
less Medicaid, so are we saving money by doing this?
That's a good question. I do not know the answer to that. I'd have to follow up.
Okay.
Historically, yes, because it's, in other words, person wasn't buying what they could access through Medicare. And it's like, so in Medicaid, we have to pick it up. So if Medicare's the first payer
Who's the primary?
and it costs X to be able to enroll that person in that program,
Right.
it was actually cheaper to enroll that person in that program to be able to get the benefits for that person and not.
That's my guess
Yeah.
intuitively, but I
Yeah.
don't know, if you're not
Historically.
immediately saying yes, then I
In
would.
most cases, Medicaid is the payer of last resort.
Yeah.
Yeah.
Do you have an answer to that question?
No.
Okay.
I mean, that's what I remember when they first did it, when they brought that idea, it was like, of course, it made sense. You know, it's like buying insurance for somebody, that X amount of dollars that you're gonna,
Right, so are we saving money? That's my question. Thank you.
Okay, next up, number 14 is Medicaid dental services for PS and CRT clients. So this is clients with developmental disabilities and community mental health and rehabilitation treatment. There's a couple of components here that are important for this committee's consideration. One, Vermont sought this capability in the 2022 Global Commitment Health Waiver. We were granted this capability by the federal government. And what this does is, one, it removes a $1,000 cap that was existing in this program, which has been a hurdle for dentists and patients alike related to that care. But also it allows us to move some money around to maximize the dollars that are at our disposal. So it's a bit of a force multiplier. So part one of this for those developmental disabilities, that we can take $50,000 from Dale, pass it over to Diva, and unlock another $68.8 thousand. So we can take that 50 grand, gross it up, and get $118,000 to use. As you can see, that's a $51.6 thousand state fund impact. And then we can also take $80,000 from DMH for the community mental health and rehabilitation treatment patients, and bring that into this pool as well for nearly a $199,000 gross fund impact. This is something that during the negotiations for the global commitment waiver, community partners also put their feedback in to help expand access to some of the vulnerable populations, and they are in favor of this as well. So we have this ability, and we're seeking approval for that as part of this request. Number 15, another theme from our BAA. This is the graduate medical education. We are requesting, oh, yeah, go ahead.
We have time. I was just going to ask you if you could slow down and just.
Sure. Do we have questions?
Nope,
No?
just, sometimes we're taking notes and some people it's,
Got it.
you know,
Certainly.
pause.
Okay. Number 15 is our graduate medical education supplemental payment. We talked about this when we came in for our BAA. We have some work to do here to request from you increased global commitment spending authority, enhancing that $30 million payment up to $51 million. So you can see the net gross result of that here is $21.2 million gross, $9.2 million state. How this works is the University of Vermont Medical Center and the state of Vermont contract together to enhance these dollars. UVM puts in a pool of money. DIVA deposits it, grosses it up, and then pulls back down a much larger federal dollar enhancement that is then passed through to the medical center that allows them to pay for postgraduate residency, staffing, programs, training, what have you. And in this environment of staffing issues and higher healthcare costs, the current methodology allows for us to enhance this funding. This is a predominantly federal program. There's no additional general funds that come from this enhanced spending authority request.
But we got two fingers up. Representative Shine, Representative Harrison, and Representative Mahali.
We all have the same question. So is this in addition to what we just did in the budget adjustment? Is it going to be kind of an annual thing?
Yes.
Okay.
Yeah.
Great. Representative Harrison?
So you said that there's no state dollars, but I'm looking at the 21.2 and then 9.2 million state.
But those come from the University of Vermont.
It's a special fund, right?
Oh,
I
They
believe
provide
so.
the-
so it's not, it's, a lot of times when we see state, we're talking about general fund, this is UVM dollars. That's the in-state match through their mechanism. And this is, I assume, only available to med schools?
Academic medical centers.
Academic medical centers, teaching hospitals, yeah.
Right, okay. Okay, thank you.
Now you've let the secret out.
Yeah, no,
No,
I
it's
opened my
good.
medical school, so,
Yeah.
in Chittenden.
Sorry. Representative Mahali.
So this, we went over some of this in BAA, but my memory is still in this early stage, short term for me. This is for residencies, for medical students,
Correct, yeah.
For
not nursing
residents.
students.
For residents.
Med
Yes.
students,
Yeah.
okay. Do we either A, have any conditions on or otherwise track where these students end up practicing? Do we, in other words, we're spending a lot of money. Are we getting doctors out of it? Is there any way you're keeping track or otherwise can evaluate the worth of these monies?
I can answer we have a contract. First of all, there's a formal arrangement in place with annual priorities that are set with the medical center. I don't know that we could track where those physicians end up, but we could certainly inquire. I don't know if we actively do that right now, but we can inquire if that's an option, A. I'm assuming they track where they go. But we have a few initiatives this year that we're working on together. And as a result of this enhanced payment, they agree to do these, prioritize the certain buckets of work that,
But those priorities, those contractual priorities don't relate to practicing in Vermont.
and not that I'm aware of. I'll confirm that.
I think that would be great because we're kind of.
I'm gonna phone a friend.
He's hurt.
We might phone a friend.
For the record, Noel Lang, Joint Fiscal Office, I'm sure that the Med School does track who stays and who goes. I don't know if they assign necessarily a dollar to a specific student. What I will say is we have other programs, such as tuition reimbursement programs and others, like AHEC, where we do track it. and they have residency required. Those are specific, where they're getting this money and they're being required to stay. Whereas this dollar is going to med school, the program might not be directed to a specific school.
Yeah, I mean, he's referring to specifically some of our programs, the students sign a note. And the note is waivable if they practice, if they stay in Vermont. And if not, it becomes due. And so I'd be really curious to know, are there any conditions that UVM puts on this money, any way they follow it? So I guess my question is twofold. One, does anybody track this? And what are the results? Yes, what are the results of the tracking?
And that would be for UVM to
For
answer.
UVM to answer,
Because
yes.
we're just a pass-through.
Yeah, but they are a pass-through, so they
Right.
could answer.
Yeah.
And these are residents, so they're going to go on to other programs potentially as well. So that would, I don't know how we would track that necessarily, but follow up on that.
Representative Mahaly, if I wouldn't mind asking, if I was speaking to UVM here, I would ask, does this program here pay for all of the residents, or is it, what percentage of residents are you actually supporting with this? Because something tells me that this isn't everybody. This is a piece of them, I think.
I think I don't know whether this falls within my portfolio.
Your
If it
UVM,
does, well, then I will pursue
Yeah.
it.
Oh, excellent.
But I would like you to pursue it as well.
We will.
You are the contracting party, and somehow I think that maybe you have even more leverage than me.
I don't know. We'll find out.
You just say you're on appropriations, they'll give you the.
good, Representative Dickinson.
Medical students or students, residents are no longer students, they're in training.
Right.
And I suspect they're there 2, 3, 4, 5 years, depending on the program. Maybe one, yeah. And I suspect it goes into do all of them, simply because that's how they do it. AHAC is done as loan repayment, and that's given to an individual. And there's criteria for that. You have to treat, and I know, you have to treat so many Medicaid patients. You have to, remember, you do it for 2 years, and then after that, you can go anywhere you want. They're all different.
I was just gonna say, they're all different.
I think in BAA, there was testimony around a couple hundred, like 250, but this
There
would
was
increase
something
to 300
general,
something.
yeah.
Yes, that's
And
right.
that the retention rate was, they
60
gave
to
us
70%.
somewhere around that, so it's a crucial part of our doctor recruitment. But Wendy from UVM, as the government affairs, could give you that data.
That's who it is. Thank you.
Yeah, right.
All right, sorry.
Somehow I asked a question and ended up getting a job, right?
You didn't realize it was in your.
Yep.
All right, number 16.
Okay. The mouthful, AFS-CME collective bargaining agreement, 568.8 thousand gross, 247,000 state fund impact. It's the estimated cost for the independent care workers agreement with the state of Vermont Children Personal Care Services. It's an amount paid by DEVA but managed by the Department of Health. And this recognizes, annualizes the effect of the current CBA.
So is the COLA, the cost, or is this the regular contract with them?
I don't know. I would have to phone a friend in Tracy O'Connell if she has any input on this one.
Hi, good afternoon, Tracy O'Connell for the record. I'm the financial director of the Agency of Food Services. And yes, this is according to the collective bargaining agreement, so this is in the second year of that agreement.
Okay, thank you.
Number 17 is a dental rate increase, 13.1 million gross, 5.7 million state fund impact. This is a governor's initiative. What DEVA is seeking is appropriations to fund an increase in the Medicaid dental reimbursement in line with 75% of Northeast Delta Dental's 2023 commercial rates. It's been several years since dentists in Vermont that take Medicaid patients have received a rate increase. So this is attempting to take a big step forward for them. There's been a lot of engagement between some of the leadership at DIVA and some dentists around the state in their capacity to continue to offer care to Medicaid members based on the rate structure as it currently exists. So this is a very significant request from DIVA and one that the department feels very strongly about attaining the funding for.
It is nice. It's a big jump. It's still 25% less than what it costs to do business, but just saying. Yep.
Well, would the,
Representative Harrison and Representative Mahaly.
My understanding was that part of the issue with dentists was because the reimbursement rates traditionally been low, you have a very low percentage of dentists taking Medicaid patients. Is that fair?
Yes.
Okay, any idea what percent?
Well, I think it has changed. I think that recently in the past year or so, we've seen a massive increase in those dental practices closing their doors to Medicaid members. So historically, they have been treating them. Many of them are no longer able to financially make that work. And it creates the tension, obviously, between commercial and a public payer.
So given this change, and I assume you with the dental society or whatever mechanism represents the dentist, do you have any idea of what percent increase we can expect to see in terms of participating dentists?
We don't have an exact percentage, but I can tell you that the feedback has been really positive in terms of, yes, we think this will move the needle. The other challenge that won't be addressed through the rate increases are the staffing issues. So that is a factor, but I do believe that those that we're considering, I can tell you that I've spoken individually with 5 practices who were ready to close their panels and are now waiting for decisions to be made in this arena. So I think it will help. I can't give you an exact percentage.
Yeah, well, it can't hurt. I mean, we're
Exactly.
but I just didn't know if you had any feel for percentage. All right, thank you.
So when you're saying closed, you're not saying they closed their practice up, they're closed to new patients.
Medicaid to new Medicaid members,
Still-
or even reduce the number of Medicaid members they can treat. Perhaps only the children needing operating room services, for example, would be an area that they would keep serving, but close their doors to 3 years old and up, which is problematic.
I wanted to understand when you said close the.
Yes, sorry.
I was like, even a rate's not gonna
Nope.
open up a shop again,
No,
you know. Well,
close their panel, Medicaid.
Did you say, Rob?
Just a quick follow-up with that. So are you gonna be able to track the number of new patients or patients served as a result of this? Is there some way to track that?
So we can track, we've been talking a lot about this and how we would measure progress. And so we have claims as an option, but that really doesn't tell you the number of Medicaid members that are treated, right? So we think we can get to unique members, but it's going to take a little drilling. We also can work directly with practices too, because we can tell how many unique members they had change in the rate, and then those that they would care for post-change. So yeah, there's still work to do there. This
Yeah,
goes
it's
well.
nice because you have some time, you can plan and you
Exactly.
can actually track it when we ask you next year how that worked.
Exactly, and I expect you will ask.
Representative Mahaly, I think I forgot you.
no. Okay, my question was answered. But thank you for remembering, Madam Chair.
I have to write it down. Go ahead.
Okay, number 18, drug coverage changes for the pharmacy benefit. This is a down of 1.8 million gross, 800,000 state. We had to reduce some of the budget pressures to align our finances appropriately with the guidance. And so the pharmacy team went into our pharmacy benefit and found, I guess, what I call the best, least worst options for finding some savings, which factors around antihistamines, melatonin, and vitamin D. We did look at nutritional supplements as a covered option, but found out that through further research, those are also available through the SNAP benefit via the Department of Children and Families, and can also be prescribed through the medical benefit with Medicaid as well, not necessarily the pharmacy benefit. So we have a budget reduction component here related to drug coverage changes.
So let me ask you a question. In my past memory, there was like this whole bank of people that are calling on coupons. Do we, on pharmacy benefits, that there is actually savings that were put into motion, that we used to have like 20 people calling on all of these coupons. I'm going to look to a friend here that might remember the days of coupon calling that the state of Vermont tried to help our. All right, he's looking
You're not
confused.
talking rebates, are you?
Rebates, maybe that, yeah, I'm calling them coupons,
Medicaid
rebates. Yeah.
Ridiculous.
Yeah,
They're definitely different. So these are actually, just to clarify, these are actually a portion of over-the-counter supplements, such as melatonin and vitamin D. These are not prescriptions, although individuals on Medicaid do need a prescription currently to fill it at the pharmacy, which then becomes covered under the pharmacy benefit. So that
it
would
just
be,
made me think of that,
yeah, I'm not sure of the coupon question.
all right, rebates, I think is the right word.
Talking about the manufacturer rebates.
Right, which is that's a different ball of wax.
Yes,
Yep.
but we still,
We still do that
Do that, okay.
for other kinds of drugs.
Oh, yes.
These are for just over the counter.
still significant.
It's very significant, yeah.
Okay, thank you.
Sure.
Okay, annual Medicare clawback changes, 2.36 million gross, 2.36 million state fund impact. This is part of the annual exercise where we determine how much money we owe back to the federal government under the Medicare Prescription Drug Improvement Modernization Act of 2003 for Medicaid Part D prescription drug program. Essentially, people who transfer the prescription drug coverage from state Medicaid programs to Medicare. There's an annual process by which the federal government comes back and essentially requires us to pay for the amount that was transferred over, and thus the clawback portion of the name. So we have an estimate here of $2.36 million in funding that would be required to cover that cost.
I'm just going to ask this out loud. So one of the things that's helpful, it might be in your book, is like this is the clawback. It's like, what was the budget for this before? This is the up and down, right? This isn't the total budget for something.
No, that's just the up part. Yep,
That's just the
yep,
up.
that's the change.
Sometimes it's nice to be able to see somewhere else that what is the budget, the whole budget for an area, and then see where the up and down is.
Yeah.
You know, if it's $100 program and the fluctuation is $50, it's a pretty big, or if it's 20 cents, it's different.
That's true. Thanks for the feedback.
Sure, go
So
ahead.
what's the trend been on the clawback?
I do not know the answer to that. I'll have to get back to you.
Yep, phone a friend.
So one way to think, get the record all night well, the Medicare Part D passed, federal government said, hey, states, we're gonna be saving you a lot of money. In return, we're gonna make you give us money back every year. So that's what this is. It's going on, I don't know, umpteen years. And I don't think there's like a trend other than they just tell us what we owe them, right?
That's my understanding of it.
Yeah, so there's no trend per se, it's just the federal government saying, you owe us this for this legislation that was passed 20 years ago.
So there's no ability to control what that amount is for this year? Okay, so then never mind my
Okay.
question. That's what I needed to know.
We don't get an explanation as to what it is. I mean, I remember when Part D passed.
Yeah,
And yeah,
so Medicare Part D was a program to help seniors pay for their prescription drugs. And at the time, we were already doing something, but the federal government didn't care. It said, hey, we're saving you Medicaid programs lots of money, so we're gonna have you help us pay for that program.
even though you're already doing it.
Even though we were already doing it, so that's good for it.
Okay.
So, but we had no choice
You just do what they tell us.
to help.
Yeah.
There's what.
Well, yeah.
If it's not something we can affect, then that's
Yeah.
important to know, so we won't spend a lot of time with angst over it.
Yeah.
Okay.
Keep going.
Okay.
20.
Number 20, proposal to eliminate the Vermont cost share reduction, VCSR, $500,000 gross, $500,000 state fund impact. This represents only 6 months of impact, as any change has to occur on a calendar year basis. So this would be effective January of 2024. VCSR is a state funded program to reduce out-of-pocket costs for eligible qualified health plan enrollees. Early on, this was used to help cover the affordability gap for Vermonters on that state exchange with a certain income level. And in that time, changes in the federal subsidies have kind of outmoded this original intent. And so we are requesting that we eliminate this, which would bring about a savings of $500,000 for 6 months in 2024.
So we would just be done with it.
Right.
Yep, correct. And the final one, Children's Health Insurance Program. These are FMAP changes, $0 gross impact, and a reductive component of $37.7 thousand. Changes in the base FMAP related to the CHIP program. And that occurs all in B310, the non-waiver appropriation. And that concludes.
That's the ups and downs. Go ahead.
Sorry, asking you questions. This is not my area, which is why I'm asking you questions. But back to number 20, the VCSR cost sharing. Does anybody get hurt by us doing that?
Thanks for the question. So I think when the program was first started, the answer would be, if we eliminated it, the answer would be yes. We have about 3,000 people on the program right now, and because of the enhanced subsidies that are available, that risk significantly decreases because of the premium costs being lower for better health plans, essentially. Our hope is that, of these individuals that are affected, they would already qualify for a better plan. And the subsidies now are extended for 3 years through the American Rescue Plan Act. So that also helps, and said, this is a really expensive program to administer. It's also a complicated program for Vermonters and doesn't necessarily serve the need that it was intended to back when it was started. So
if there's 3,000 people on this program now, what are you doing to help them transition to something that will still keep them okay?
Yeah, sure. So we have, because we also administrate the health insurance exchange, Vermont Health Connect, we would connect them with the plans that would be available to them with increased subsidies. I think 90% of individuals on the exchange actually have some sort of subsidy availability right now.
Okay, so you have staff to do that and help these 3,000.
So the same staff that are doing all the other eligibility work, but yes, that would be a priority if this moves forward and we eliminate the program.
Okay, thank you.
It sounds like it wouldn't just happen naturally as people renew. It would be a better program over here, so this one's getting used less.
It is getting.
Because you're not doing.
Utilized less. There's still a few thousand.
Right.
We're done.
All right.
All 21 requests.
Wow.
Can we go through the book?
How much time do you have?
We have you until what?
I think you needed a longer lunch break, I heard.
3:00.
Madam Chair.
I have to be somewhere at 3:15, but you guys don't necessarily have to. Any other, this is Representative Page's section of the budget. So we'll funnel questions through you.
Absolutely.
By the hundred, yeah.
By that.
By the hundred.
Is all this information in the book as well?
So based on
I figure where to file this.
Yes, but based on the corrections that we pointed out around the ISF, plug that in lieu of downs in the narrative that are in there. Because those are
Page 53, I think,
minor
is where it
housekeeping.
begins.
Right around. Anything in here you'd like to point out? Show us your highlights.
I think it's a really valuable tool for you to go through. I think probably for newer members of the committee, we tried very hard to make it, to help people understand what DIVA does and what each unit within DIVA does, because it's very complex and the work stretches across the agency. So we go unit by unit. Here's what the payment reform unit does. Here's what the pharmacy unit does. So I think that is one area. I would look at our priorities as well of where we're focusing our efforts moving forward as we unwind from the public health emergency, which I know I'm not supposed to use the term unwind. It is really about redetermining Medicaid eligibility. That's a really helpful section in there for you to understand what we're required to do. And I think the ups, downs are, we've already gone over those today, but in the back, there's also a helpful acronym glossary. So I think that's probably the biggest highlight I can offer you today. It's pretty special.
And it's not 28 pages long.
No, it was 36 when we started. So this is a huge improvement, and it's only the acronyms that are actually in the book.
And you didn't change the type to 8-point either, it's legible, so to get it down to lower.
Well, many thanks to our Director of Legislative Affairs and Communications, sitting to my right, for the hard work she did on this.
So I always find well, in the past, page 75, which gives you that category of service, the 22 actual spent, the BAA, and then the 24.
Yes.
You can see it,
Yes, you can see the
that's-
trends that way. Yep.
that's the piece.
That's, the fiscal section is super helpful as well, but it does take some time. If you're interested in payment.
Well, we might need a tutorial on making sure we read this right. That's my only, when I read it and I think, oh, that must be what that means. When I think to myself, oh, that must be what it means, and I stop myself from thinking, because must be is not a really, I like to know for sure.
For sure, right?
Yeah.
Like, and that is what we're trying to do with the book, is lay it out in a format that makes sense to folks.
So, yeah, that's a good piece. Representative Harrison?
Commissioner, this predates you, but a few years ago, we had a problem with the whole health exchange from a technical aspect. Have those issues largely been all resolved?
Thanks for the question, Rep. Harrison. I would say that they have improved tremendously. And part of that is because we have a fairly robust new contract with a different vendor that has helped us work through some of those technical difficulties that we had early on in the exchange. I think that from the end user like Vermonter accessing the system, I think there's still improvements to be made. But in terms of how things work on the back end, like behind the scenes, market improvement. And, the teams, to their credit, we have a lot of individuals working on this every single day, and they have done an amazing job, in my opinion, in the short time that I've been here. I heard about all of the history, and I still hear about the history, but we're looking to put that behind us also.
No, and as a legislator, I haven't heard much
Good,
in the last few years, but prior to then, we heard a lot.
good. I'm happy to hear that you're not hearing about it.
But I guess my question is because IT projects, have a shelf life. And, this system, I don't know, must be 10 years old now or
Yep.
10 years old. And at what point do we have to upgrade it to something new? And are we planning for that? And maybe not. I mean, we let the UI system go 40 years. But I don't think we want to do that.
No.
I don't want to do that either. But yes, we're planning, yes, we're actively working on these projects. The integrated eligibility and enrollment project is an ongoing thing. I think the misperception about technology is that you actually get a thing at the end. You don't get a thing necessarily at the end, but you get efficiencies and you get improvements for Vermonters to be able to access the programs they need. And be able to do that and navigate it on their own, because healthcare is complex. So there are constant programs in motion. Many of them are large, like the Medicaid data warehouse, the integrated eligibility and enrollment. So the answer is yes. The challenge is when you have existing technology, if you try to fix one thing, you break something else. And so you need to just be mindful, and that's what we try to do.
Yeah, no, and I appreciate that. And government complicates it because the rules keep changing. Which is why we've done things with our tax software that, is getting adjusted and modified every year.
Yeah, the requirements do change and the guidance changes from CMS for us. Yeah. Thanks for the questions.
Anybody else? Anything?
No question.
You're free to go.
Thank you.
Thank you for your time.
Thanks for having us
Thank
today.
you.
Hope you get a longer lunch.
Yeah.
Thank you.
The 500,000.
Oh, I'm
like-
sure. I just wanted to understand.
It's two different things. Two different things.
We can, Aaron, we can